I was asked to talk about the need for oral lead-ins and how to cover the tail of injectable long-acting regimens. So the first question is, do we really need an oral lead-in? The most recent data from ViiV suggests that the oral lead-in for cabotegravir may be dispensable. It was developed because the safety and tolerability of cabotegravir was not well known when the drug was first developed as a long-acting injectable. And so the oral lead-in was to make sure that participants in the phase 1, 2, and 3 studies tolerated the drug before they were given an injection with drug concentrations that would hang around for 6 months or longer. But in these recent studies presented at the Glasgow meeting last year, a regimen in which the oral lead-in was dispensed with was non-inferior to the standard oral lead-in arm. And so the oral lead-in is in the lighter green here. The regimen without a lead-in, that is the direct-to-inject regimen, in the dark green. And the virologic efficacy was equivalent, and the safety and tolerability was excellent. And in part, this could be done because we now know that cabotegravir, even in its injected format, is quite well tolerated by almost everyone. So what's the best way to cover the tail? Well, we know from pharmacokinetic data that's previously been published that the tail for cabotegravir can be quite long, lasting more than a year in some people after only a single injection. And unfortunately, we also now know that when combined with rilpivirine for treatment, you can develop resistance to cabotegravir. And we also now know from the HPTN 083 studies that when used as PrEP, cabotegravir monotherapy can also fail and promote the development of resistance. And so here are some of the risk factors for resistance and treatment failure on the 2-drug treatment regimen. And that includes, in this case, rilpivirine RAMS, the rilpivirine trough concentration at week 8, interestingly, not the cabotegravir concentration at week 8, baseline viral subtype and body mass index. But none of these factors probably are substantive enough, with the exception of rilpivirine resistance mutations, to allow one to screen for people who will or will not have a high likelihood of failing these regimens. And so what's the best way to cover the tail? I think the best way to cover it is don't let it happen. I think we need to develop systems for making sure that our patients receiving these drugs come in and get them on time to avoid the possibility of resistance as a consequence of inadequate pharmacokinetics. So I'll stop there and be happy to join in the discussion.